this baby roll.
The subcommittee will come to order. Good afternoon, everyone. Every dollar lost to Medicare fraud is a dollar stolen from America's elderly. And every dollar lost to improper payments, intentional or not, robs from the solvency of this important program. Today's hearing will examine the issue of Medicare fraud. This is a bipartisan concern shared by our seniors, the Medicare program, and lawmakers on this committee. The Office of Inspector General, which is testifying here today, cites that nearly $50 billion is lost to improper Medicare payments each year. That is an alarming amount. I'm also alarmed by how often I open the Houston Chronicle back home to find stunning investigations of Medicare fraud that runs into tens of millions of dollars, involving doctors, ambulance companies, mental health clinics, and even patient advocates, those who are tasked with protecting the sick and elderly. Last Friday brought news of a 13-count indictment of providers in Florida and the Houston area for allegedly billing Medicare for services that were not needed and providing kickbacks for patient referrals. Last Wednesday, it was the sentencing of a Houston area woman after her 2013 conviction for defrauding Medicare. These stories are all too frequent in communities around the nation. To make matters worse, in the past year, the Office of Inspector General has documented evidence that Medicare is paid for services to those who are deceased, in prison, and not entitled to benefits. All this while Medicare's main trust fund is on a crash course with insolvency in a short 12 years. President George W. Bush established the Federal Medicare Fraud Strike Force in 2007 that changed to a much more aggressive approach to Medicare fraud, and it is starting to bear fruit. In response, the Centers for Medicare and Medicaid has taken strides to address this growing problem. The agency has used its authority to impose a temporary moratorium on the enrollment of certain providers in high-risk areas, including preventing new ambulance companies from billing Medicare in my home state of Texas. However, more must be done to protect our seniors and taxpayers. While a moratorium on new providers may very well prevent unscrupulous providers from entering the program, it doesn't stop those who've already enrolled in improperly billing. More must be done to move from the outdated pay and chase approach to a new 21st century approach, which stops improper payments before they go out the door. I'm also concerned about the CMS lack of leadership and interest in problems that are especially embarrassing for the Medicare program. Preventing payments for services to those who are dead or are in jail involves a straightforward fix. It is still a problem, regrettably still a topic for discussion at this hearing. And that is the focus of this hearing, not merely identifying the fraud and abuses, but identifying what can be done using new technologies and successful strategies to prevent and deter fraud in the future. First, I commend my colleagues on this committee, members on both sides of the aisle who have introduced bills that make common sense changes. For example, my colleagues and fellow Texans, Mr. Johnson, Mr. Doggett, have been working on a legislative fix for nearly a decade to take Social Security numbers off of Medicare cards. And you see bipartisan efforts throughout this subcommittee. It's frustrating that such a simple fix is yet to happen. I look forward to the day when I can tell my seniors in my district that they no longer must worry about having their Social Security number compromised simply by carrying the Medicare card they need to access their health care. Secondly, we're interested in hearing recommendations from the OIG and the Government Accountability Office. These watchdog entities have identified vulnerabilities and proposed solutions in the areas of improper payments and CMS oversight of claims paying and fraud-fighting contractors. Many of these recommended fixes support bills that members of Congress on this committee are championing. Thirdly, we'll hear from CMS about its program integrity efforts. While we're interested to hear what the agency's done, we're perhaps more interested in what it plans to do going forward. The written statements from our witnesses make clear that much work is left to be done. Lawmakers have ideas, OIG and GAO have made recommendations, and CMS has its plans. So let's identify the ideas that solve our problems and get to work now putting them in place. It's not important who comes up with these ideas on fighting fraud, waste, and abuse. What is important is that we act on these good ideas. It's my intent that we move forward on a bipartisan basis, working with CMS to protect our seniors, bolster the Medicare Trust Fund, and ensure appropriate use of taxpayer funds. Before I recognize Ranking Member Dr. McDermott for the purposes of an opening statement, I ask unanimous consent that all members' written statements be included in the record. Without objection so ordered, I now recognize our Ranking Member, Dr. McDermott, for his opening statement.
Thank you, Mr. Chairman. I want to commend the Chairman for having this hearing. I think the controlling of costs as we move forward in health care is going to be the toughest issue we face. This administration has been serious about combating fraud, waste, and abuse. The joint effort of Attorney General Holder and Secretary Sebelius through the Healthcare Fraud Prevention and Enforcement Action Team, so-called HEAT, there have been measurable results. The team has recovered in excess of $4 billion every single year since 2011. That's real money. There was a time when a hearing on Medicare fraud such as this would have focused solely on the dollar amounts recouped at the back end after the fraud had been perpetrated, and any money that could have been recouped would have been long spent. Then came the Affordable Care Act, which gave regulators additional new powers to prevent fraud rather than just reactively address it. Powers such as expanded payment suspension authority and the requirements to effectively police who gets into the Medicare program, ensuring Medicare participation is reserved for scrupulous providers and suppliers. So now, when we talk about our fraud prevention efforts, we speak a different language than even 5 years ago. We speak of payment suspensions in greater numbers. We speak of high-risk or moderate-risk providers and suppliers. We're talking about fingerprinting owners of the high-risk providers and suppliers. We speak of the fraud prevention system and the predictive analytics designed to monitor for potential fraud on a real-time basis. Notwithstanding all the efforts that have been made at transforming Medicare and Medicaid into programs that hold participating providers and suppliers accountable, as the Chairman has said, much more work needs to be done. With alternative delivery system models, what does fraud, waste, and abuse really look like? With the expanded waiver authority that essentially granted federal agencies the ability to issue wide-open waivers, what new fraud schemes will emerge? So our important work in this area is not done. Much more work remains. I know the GAO will continue to play an important role in helping us with our oversight responsibilities, and the OIG and CMS will use their expanded authorities to root out the fraud, waste, and abuse to preserve the Medicare and Medicaid programs for the future. I look forward to working with the Chairman on a bipartisan basis on these issues. I yield back the balance of my time.
Thank you, Doctor. Today we'll hear from three distinguished witnesses. Gloria Jarman, Deputy Inspector General for Audit Services at the Office of the Inspector General at the Department of Health and Human Services. Kathleen King, Director of Health at the Government Accountability Office. And Dr. Shantanu Agrawal, Deputy Administrator at CMS and Director of Center for Program Integrity. We've reserved 5 minutes for each of the opening statements, and we'll explore the testimony further during questions. Ms. Jarman, you're recognized.
Good afternoon, Chairman Brady, Ranking Member McDermott, and other distinguished members of the subcommittee. Thank you for the opportunity to discuss OIG's work related to Medicare oversight and reducing fraud, waste, and abuse. We have a lot of work in this area. Today, my statement focuses on our recent work related to improper Medicare payments and billings and oversight of Medicare contractors. CMS needs to continue to take steps to reduce improper Medicare payments and improve its oversight of the various Medicare contractors. Improper Medicare payments cost taxpayers and beneficiaries about $50 billion a year. In recent work, OIG has identified millions in improper payments made on behalf of persons not entitled to Medicare, such as incarcerated, unlawfully present, deceased, or entitlement terminated individuals. While some progress has been made by CMS in these areas, it needs more accurate and timely information to trigger payment edits and better procedures to detect and recoup these improper payments. OIG has also uncovered extreme prescribing patterns by hundreds of general care physicians and questionable billings by thousands of retail pharmacies. Medicare also paid millions for prescriptions from unauthorized prescribers such as massage therapists and athletic trainers. This is especially concerning in light of OIG's increasing investigations into drug diversion. Verification of prescriber authority, edits, and enhanced monitoring are necessary to safeguard Medicare Part D and ensure patient safety. Recently, we have also reported improper payments to hospitals of millions of dollars related to vulnerabilities we identified as part of our nationwide hospital compliance reviews. In addition, we found that Medicare could have saved about $638 million over just a 2-year period by establishing a hospital transfer payment policy for hospice transfers and strengthening billing requirements. OIG has made specific recommendations to reduce these and other improper payments, but those steps alone will not adequately safeguard Medicare. CMS must continue its efforts to improve its oversight of Medicare contractors. CMS relies on contractors to administer various parts of Medicare, including claims payment, identification, and recoupment of overpayments, and benefit integrity functions. Our work has identified vulnerabilities associated with CMS's oversight of contractors. First, CMS has not fully leveraged data to improve oversight. Part C and Part D plans report fraud and abuse data on merely a voluntary basis. CMS does not mandate such reporting. Under this system, we found that less than half of the Part D plans have actually reported fraud data, and reporting varied significantly from plan to plan. In addition, CMS has made limited use of the data it has received in overseeing Part C plans and has not fully used reported fraud and abuse data for monitoring Part D. As a result, CMS is still missing opportunities to discover and alert plans and law enforcement to emerging fraud and abuse schemes. Second, we have found that while CMS's performance reviews of Medicare administrative contractors, or MACs, were extensive, they were not always timely. If performance reviews are not completed and performed timely, the information they contain may not be available to support future contracting decisions. To improve contractor oversight, we've made several recommendations to CMS that are included in our compendium of priority recommendations on our website. While my testimony focuses on our work to help CMS improve program operations, I would like to make a request that would help OIG better meet our growing oversight responsibilities. OIG is responsible for oversight of about 25 cents of every federal dollar spent. But our mission is challenged by declining resources at a time when our oversight responsibilities are increasing. By the end of this fiscal year, OIG expects to reduce Medicare and Medicaid oversight by about 20%. During the same time, 2012 to 2014, outlays for Medicare are expected to grow by about 20%. To ensure that we can continue to provide needed oversight as these programs expand, we ask for the committee's support of our 2015 budget request. In summary, we remain very committed to carrying out our responsibilities in the area of improving Medicare oversight to reduce waste, fraud, and abuse as comprehensively and effectively as possible with the tools and resources we have available. Thank you for your interest and support. I would be happy to answer your questions.
Thank you. Mrs. King?
Mr. Chairman, Ranking Member McDermott, and members of the subcommittee, thank you for inviting me here to
Ms. King, is the microphone on there?
Sorry.
No.
Thank you for inviting me to talk about our work regarding Medicare fraud, waste, and abuse. CMS has made progress in implementing several recommendations we identified through our work to help protect Medicare from fraud and improper payments, but there are additional actions they should take. I want to focus my remarks today on 3 areas: provider enrollment, pre- and post-payment claims review, and addressing vulnerabilities to fraud. With respect to provider enrollment, CMS has implemented provisions of the Patient Protection and Affordable Care Act to strengthen the enrollment process so that potentially fraudulent providers are prevented from enrolling in Medicare, and higher risk providers undergo more scrutiny before being permitted to enroll. CMS has recently imposed moratoria on the enrollment of certain types of providers, in fraud hotspots and has contracted for fingerprint-based criminal background checks for high-risk providers. These are all positive steps. However, CMS has not completed certain actions authorized by PPACA, which would also be helpful in fighting fraud. It has not yet published regulations to require additional disclosures of information regarding actions previously taken against providers, such as payment suspensions. And it has not published regulations establishing the core elements of compliance programs or requirements for surety bonds for certain types of high-risk providers, including home health agencies. With respect to claims for payment, Medicare uses prepayment review to deny payment for claims that should not be paid, and post-payment claims review to recover improperly paid claims. Prepayment reviews are typically automated edits in claims processing systems that can prevent payment of improper claims. We found some weaknesses in the use of prepayment edits and made a number of recommendations to CMS to promote implementation of effective edits regarding national policies and to encourage more widespread use of local prepayment edits by Medicare Administrative Contractors, or MACs. CMS agreed with our recommendations and has taken steps to implement them. With respect to post-payment review, we recently completed work that recommended greater consistency in the requirements under which 4 post-payment review contractors operate, when it can be done without impeding the efficiency of efforts to reduce improper payments. CMS agreed with our recommendation and is taking steps to implement them. We also recommended to CMS that they collect and evaluate how quickly one type of post-payment review contractor, the Zone Program Integrity Contractor, takes action against suspect providers. CMS did not comment on this recommendation. We also have further work underway on the post-payment review contractors to examine whether CMS has strategies in place to coordinate their work and whether these contractors comply with CMS's requirements regarding communications with providers. With respect to vulnerabilities to fraud, we have made recommendations to CMS over the last several years, and CMS has implemented several of them, including establishing a single vulnerability tracking process and requiring MACs to report to them on how they have addressed vulnerabilities. However, CMS has not taken action to address our recommendations to remove Social Security numbers from Medicare cards, because display of these numbers increases beneficiaries' vulnerability to identity theft. We continue to believe that CMS should act on our recommendations, and we are currently studying the use of electronic card technologies for Medicare, including potential benefits and limitations and barriers to implementation. Because Medicare is such a large and complex program, it is vulnerable to fraud and abuse. Constant vigilance is required to prevent, detect, and deter fraud so that Medicare can continue to meet the health care needs of its beneficiaries. This concludes my prepared remarks. Thank you, Mr. Chairman.
Thank you, Ms. King. Dr. Agrawal.
Thank you. Chairman Brady, Ranking Member McDermott, and members of the committee, thank you for the invitation to discuss the Centers for Medicare and Medicaid Services program integrity efforts. Enhancing program integrity is a top priority for the administration and an agency-wide effort at CMS, and we have made important strides in reducing waste, abuse, and fraud with the strong support of this committee and Congress. I know that this also is an area of particular interest to the members of this committee, and I look forward to hearing your input and working with you on strengthening program integrity in the Medicare program. Before proceeding, I would like to take a moment to introduce myself. I'm a board-certified emergency medicine physician. For the past several years, and concurrently with other positions I've held, I've continued to work as an emergency medicine doctor, both in large academic centers and an area community hospital. Shortly after completing my medical training, I joined a management consulting firm where I had the opportunity to help hospitals, health systems, and biotech and pharma companies improve the quality and efficiency of healthcare delivery. In 2011, I joined CMS to serve as the Chief Medical Officer of the Center for Program Integrity, where I had the chance to apply both my medical knowledge and private sector health experience to helping CMS fight fraud and ensure quality care for the millions of patients insured through Medicare and Medicaid. I view program integrity through the lens of these experiences and as a physician who fundamentally cares about the health of patients. Our healthcare system should offer the highest quality and most appropriate care possible to ensure the well-being of individuals and populations. CMS is committed to protecting taxpayer dollars by preventing or recovering payments for wasteful, abusive, or fraudulent services, helping to extend the life of the trust fund. But the importance of program integrity efforts extend beyond dollars and healthcare costs alone. It is fundamentally about protecting our beneficiaries, our patients, and ensuring we have the resources to provide for their care. Numerous experts have cited the waste endemic to our system, caused by multiple factors, from inefficiencies in care delivery to outright fraud. Underlying the issues and numbers are real patients. We are all too familiar with the stories of a patient getting inappropriate care or services due to the malfeasance of others to defraud our system. When providers and suppliers are influenced by their own financial interests or incentives, this can lead to upcoding or other gaming of Medicare and Medicaid. Fraud is not merely deception for dollars through falsified billing. It threatens beneficiary health through blatantly unnecessary services, substandard or non-existent care, dangerous prescribing through pill mills, and a host of other schemes. Examples of such waste and abuse are driving our agency and my team to rethink the way it approaches program integrity. Due to new authorities and resources provided by Congress over the past few years, CMS is changing the program integrity paradigm toward a focus on prevention and collaboration to identify and combat waste, abuse, and fraud in our system and in partnership with other stakeholders. As Deputy Administrator, I will continue to lead CMS on this course with three main areas of intention: coordination across the agency and the broader healthcare system, excellence in program integrity operations, and a clear view towards improving the cost and appropriateness of care. First, coordination. The Center for Program Integrity is responsible for leading and coordinating agency efforts to reduce waste, abuse, and fraud. Collaboration with stakeholders external to the agency is vital as well for the identification of vulnerabilities and increasing our impact. Led by the interagency HHS-DOJ partnership, HEAT, the federal government made its highest recovery of funds this past year, $4.3 billion in FY13. This resulted in the highest return on investment in the HICFAC program, $8.10 for every $1 invested. We are continuing to build on existing partnerships with private sector payers, healthcare organizations, and providers through our public-private partnership. Results from the initial data exchanges under the partnership have helped identify fraudulent schemes and specific providers impacting private and public payers and led to CMS administrative actions such as revocations as well as law enforcement referrals. Second, operational excellence. CMS has robust measures of the return on program integrity appropriations, the result of audit and investigation activities, and the impact of advanced data analytic systems, all of which show strongly positive returns on investment. I intend to build on this foundation by managing performance and strategic decision-making based on the areas of greatest risk and return. In particular, CPI's work on provider enrollment and screening has enhanced program integrity while lowering burden for providers. Finally, the cost and appropriateness of care. CMS has a comprehensive program integrity strategy that includes multiple tools and interventions that are used individually and in tandem to tackle specific vulnerabilities. By applying these tools across Medicare and Medicaid in a coordinated way, CMS can impact the overall cost of care. We can and should aim to do even more. As just one example, CMS has been piloting the use of the fraud prevention system, which is applying predictive analytics technology to all streaming Medicare fee-for-service claims to identify not only potentially fraudulent providers for investigation, but all providers who are billing inappropriately and may require education or medical review. Thank you for your time and opportunity. I appreciate your support in achieving these goals. I look forward to hearing your ideas on how we can work together as we continue to focus on beneficiaries and strive every day to protect their health and well-being.
Thank you, Doctor. Thank you to all the panelists. Dr. Agrawal, you've highlighted a number of actions CMS has taken to reduce waste, fraud, and abuse, and we appreciate them. While your fellow panelists acknowledge that your agency has made progress, the Inspector General Accountability Office identified a number of areas for improvement. I'm particularly troubled by the Inspector General's revelation that Medicare pays for services that those who have died, $23 million, according to the testimony, $117 million lost to those unlawfully present, and $33 million paid to those in prison. And there is more. Fraud within the fee-for-service area, over-prescribing by physicians, the hospital transfer payment issue, which is more than $500 million lost to Medicare, These are problems that hurt seniors and erode public confidence in the Medicare program, and to my mind, reading the testimony, are preventable. I truly believe that preventing fraud is a bipartisan issue, has been a long-standing challenge. And my hope is that we can work collaboratively with CMS. And since this is your first time before the House and before the committee, can I get a commitment from you that your agency will work with me and our committee to stop the nearly $50 billion in improper payments each year?
Thank you for the question. Focus on improper payments is absolutely very important for the agency. We appreciate the work of the OIG and the GAO in identifying further vulnerabilities that we can work on. I think we can all agree, and it has been stated, that these are areas that we've made important progress in. That's not to say that we should stop being aggressive on these issues. I think there are numerous factors in our more recent kind of programs that have provided important progress. So work that we've done on enrollment and screening standards, on advanced analytics, have, I think, really started to and made significant strides in addressing improper payments, as well as the other improper payment issues that OIG and GAO have identified. We will continue to work on those and look forward to working with this committee in doing so.
It'll go easier if you just start with a yes, just so you know.
Yes, sir.
Dr. Alwell, thanks for your willing to work with as a follow-up on the fundamental challenges that you have and will face is moving CMS from a pay-and-chase fraud-fighting model. I'm glad you mentioned it in your written statement, but I'm concerned your efforts focus mostly on recouping money that's already gone out the door. Many members on this panel, again bipartisan, believe we should be copying what private payers are doing already to prevent, detect, and deter fraud, stopping payments before they go out the door. And so what actions is CMS taking to move in that direction, and how do we as a committee measure that movement and those results?
I think that's a very important question. We have taken a lot of steps to both emulate the private sector where appropriate and work with the private sector in our common program integrity challenges. As one example, we have recently completed a demonstration on the use of prior authorization to mitigate improper payments as well as other fraud, waste, and abuse issues, and there's language in the President's budget that would allow us to expand that program. Another example, I think, a notable one is the Healthcare Fraud Prevention Partnership, which specifically brings private payers together with CMS in order to jointly and in a coordinated manner detect and prevent fraud. Under that partnership, we have already engaged in numerous data exchanges and also sort of qualitative exchanges around best practices. It's led to some real actions for us. The way that I think you could measure them is similar to how we measure them. We look at identified savings from HFPP activities as well as other activities and specific outcomes like revocations and law enforcement referrals.
Ms. Jarman, in her testimony, laid out a number of recommendations, but more importantly, what seemed to be fairly simple sharing of data that would have prevented improper payments in a number of areas. Why aren't those being done?
Well, sir, I think there are multiple examples of where we are sharing data. We are sharing data with state Medicaid agencies, with the private sector, with law enforcement, and all of those examples are really bi-directional sharing of data. So we are getting data from them and learning from all of these entities as well as providing our data to these other parties. There is certainly more that we can do, and we continue to expand our data sharing activities. I'm happy to continue to work on those, but I think there are really notable examples in numerous programs where data exchange is central to those programs.
Thank you. Ms. King, I understand GAO generally directs CMS to make recommended changes for which the agency has administrative authority, and that General Accountability Office recommendations that require legislation are directed to us in Congress. Can you give us, so that we can track these and so we can measure the progress and know where we need to focus, can you give us a rough percentage of the GAO unimplemented recommendations that CMS has authority to implement, and your sense of why it has not yet acted?
We do track all of our recommendations over time, and we keep them open for a considerable period of time. And I don't have the exact numbers at my fingertips, but our track record is pretty good. on whether they have been implemented. And we have supplied to your staff a list of the open recommendations.
But approximately how many are there? I'm not trying to pin it down. I'm just trying to figure out.
Geez. Off the top of my head, 20 to 30.
In what area, to put in perspective, these 20 to 30, roughly, what potential impact do they have? How important are these recommendations not yet implemented for either stopping improper payments or recouping them once done?
Well, I don't think we make a recommendation unless we think that it is going to have a real effect, that we identify a problem and we identify a way that it can be fixed. And some of those recommendations are actually not on the improper payment side, they're for all of Medicare, and some of them go to changes in payment policy, and some of them go to changes in management, and others do go to improper payments. And I think on the improper payment side, I think a good many of those recommendations have been implemented or in the process of being implemented. And we don't close a recommendation until we're satisfied fully that it has been implemented.
Right. And you've shared that information with us?
Yes,
Correct.
sir.
And we'll make sure the committee has it. Ms. Jarman, I've introduced legislation with my colleague, Dr. McDermott, that would expand your authority to exclude individuals and companies from participation in Medicare and other federal programs. Our intent is to prevent individuals who are responsible for fraud from jumping to another company before sanctions are headed down, and to prevent a company from creating a shell company to further commit fraud and shield the parent company from liability. That's the intent of the legislation. While I think these situations, we can all agree we need to prevent, several types of providers have understandably expressed concern that this expansion could leave companies that serve seniors at serious legal risk, even if they have no role in fraudulent activity exposed to the OIG overreach. So how do you respond to these concerns?
Well, I'd like to note that OIG, we don't have the resources to actually go after all of the people who maybe should be excluded. So the chance of us even going broader is very limited. We are very careful about how we use the authorities that we have. We have guidance on our website, and as far as reasonable factors to consider when deciding to do an exclusion, which includes the seriousness of the misconduct or the alleged fraud, and whether it harms beneficiaries or the health plan. And this exclusion authority is very important to us because we do need the authority to be able to exclude people who actually leave the organization before the citation, who have been accused of fraud. So that was a loophole in the prior legislation that's very important that we fit so that the wrongdoers would be able to be excluded. But we're very careful to make sure.
Thank you. Dr. McDermott and I are very serious about closing this loophole and stopping this jumping from company to company, and it continues to be a problem. So now I recognize Ranking Member Dr. McDermott for 5 minutes for his questions.
Thank you, Mr. Chairman. Ms. Jarman, I appreciate your testimony and recognize that you are with the Office of Audit Services component of OIG, and I have questions that are more appropriately perhaps addressed to the Office of Counsel within OIG. Therefore, I want to make a statement, and I will submit several questions to the record, and we'll look forward to the responses from the OIG. I remain concerned about the application of our current fraud and abuse laws, given our movement to new payment methods. My concern exists on several levels. First, I believe that federal regulators have sufficient experience with some models such that these arrangements should not be afforded protection under broad waiver authority, which is unclear exactly how the False Claims Act applies and where whistleblowers can be may be reticent to bring qui tam cases. Instead, regulators should put forth, I believe, an appropriate exception under the self-referral law and make modifications to other laws, including the gain-sharing, civil monetary penalty law as necessary to provide parameters for such conduct. As an example, I'm aware that OIG has issued no fewer than 15 advisory opinions. I've read some of them, not all of them, on various incentive compensation programs between hospitals and patients and physicians. And, Mr. Chairman, I would like to enter into the record these advisory opinions that OIG has issued since 2001 in the area of incentive arrangements between hospitals and physicians.
Without objection.
Rather than issuing case-by-case advisory opinions, it seems to me that more structure should be put in place around such arrangements. This would allow regulators to better monitor these arrangements and would afford participants some level of certainty that participation in such arrangements would not be problematic under the fraud laws. My bill 1487, H.R. 1487, it's called the Improved Care of Lower Cost Act of 2013, seeks to require regulators to provide more structure around certain arrangements that regulators have been approving for over a decade on a case-by-case basis to allow broad participation by providers, but also ensure inadequate scrutiny by regulators. This case-by-case thing is, as we spread the Accountable Care Act over the country, you're going to have endless case-by-case things, and I think it ought to be done systematically. Secondly, I remain concerned that there are new fraud, waste, and abuse schemes that we may not be fully aware of, given the different incentives under emerging payment models. So everyone agrees and usually mentions that we need to be concerned about stinting on care for Medicare beneficiaries. One of the ways you can save money is don't give care. But what about monitoring whether a few unscrupulous providers would game the system by manipulating quality measures, since these measures have taken on an increased importance in this new era of healthcare? All patients have to say is, I like the doctor and that they've got good quality. That doesn't mean they have gotten the care they needed. This conduct seems to me to be much harder to identify than a false storefront, for example. This type of fraud is just as detrimental to our beneficiaries as to the solvency of the Medicare Trust Fund. And I'll submit these questions in writing to the Council. I'm also a co-sponsor of a bill, H.R. 2914, the Promoting Integrity in Medicare Act, which would retain but narrow the in-office ancillary services exemption under the Physician Self-Referral Act so that the law and implementing regulations would more closely approximate what Congress intended. CBO has suggested that the change reflected in this legislation would save the federal government $3.4 billion over the next 10 years. And Ms. King, can you provide the GAO's key findings related to the in-office ancillary services exception and the existing policy in this area?
Yes, we've done a few reports on that, and what we have found is that in instances where there is an ownership interest, that the utilization is higher, and in our view, the self-referral component of it is one of the primary driving forces behind the higher utilization. And we have made a recommendation to CMS that they more closely track when services are provided in a self-referral situation, but they did not agree with us on that. And we wish they had, and we wish
Could you give us their reasoning that they gave you when they didn't agree with you?
They said that they thought it would be really complicated to track.
It would be complicated to track.
Yes, sir.
And since it's complicated in this day of computers and programming and all the rest, they couldn't figure out how to do it. Is that what you're telling me?
Well, sir, I can't speak for them, but that's what they responded.
Dr. Egerwald, does that make sense to you?
Sir, I appreciate the question and I appreciate the issue that you're raising. I would say that Stark and self-disclosure laws don't actually fall within the activities of the Center for Program Integrity. I'm happy to take your comments back and connect you with the right expert at CMS.
All right, if you would, I would appreciate it, because I think that when there's this much money on the table, as there is in healthcare today, it's bound to attract some folks who don't have the best interests of the patients or the government or the taxpayers at heart. And it's going to be difficult for us. It's certainly with Medicare, we've got problems already. We're going to have more problems with the Accountable Care Act, and I think it's important that these fraud laws be updated to move from fee-for-service application, which is what we've had in the past, to now these more complicated other payment arrangements for physicians. As physicians are hired by hospitals or get into relationships with hospitals, the whole of the fraud thing changes, or at least it seems to me it changes. And I want us to look carefully at that and make the kinds of changes we need to, so that we don't come here 5 years from now and say, here's $100 billion that's been wasted, or $50 billion, or whatever. I want us to try and stop it before it starts. You back the balance.
Thank you, Mr. McDermott. Mr. Johnson is recognized.
Thank you, Mr. McDermott. I agree with you. They refuse to do anything. Dr. Agrawal, I understand you're now in charge of the CMS program integrity mission. Is that true? True or false?
Sir, I am in charge of the Center for Program Integrity, yes.
Okay. You may not know, but in recent years, the House has twice overwhelmingly passed bills to take the Social Security number off the Medicare card. My colleague Lloyd Doggett and I have been trying to get this done for years, and it seems to us that CMS, who tells seniors they must carry their Medicare card with their Social Security number in their wallet, refuses to protect seniors from becoming victims of identity theft. And you know, you talk big about doing things over there, but you guys haven't done anything. Do you care about protecting seniors from identity theft?
Unequivocally, yes, sir. We care about protecting seniors from identity theft.
Well, we have taken do that.
We have taken a number of actions to do so. We have, for example, beneficiary education activities, campaigns in order to make them more aware of identity theft issues, given them real tactical solutions and ideas for how to not be victimized by identity theft. Beyond that, sir, when it looks like somebody has become a victim of identity theft, we have a way of tracking their existing numbers and incorporating that through our compromised numbers database into other analytical work that we have underway. So we are able to use that information in our activities to help prevent fraudulent billing under their HICN.
Yeah, but how are you going to stop them from stealing their Social Security number off of your Medicare card?
Well, I appreciate the issue, and I realize its importance to this committee. I also know that you're very aware of the dialogue that the agency has had with the committee and the operational kind of requirements in order to be able to remove the Social Security number from the card. I think given the right resources to be able to do it, we would be very open to further discussion on
well, you
meeting
could
that
at least
requirement.
just put the last 4 digits on there instead of the whole number. Does CMS support our bipartisan bill, H.R. 781, the Medicare Identity Theft Prevention Act of 2013, yes or no?
Sir, I'd have to review the specifics of that bill to give you a
How long have you been
definitive
there?
answer. Pardon me?
How long have you been there?
2 months.
Well, you ought to know it by now. When are you going to do something about it? I'd like to know what your plan is and when CMS will try to do the right thing. Ms. King, GAO told us that CMS has efforts underway to modernize their IT systems and that these efforts could be used to remove Social Security numbers off Medicare cards, yet CMS has not included removing Social Security numbers, and he just talked about it. Is it still true that you agree with that?
Yes, sir, it is. I mean, I think CMS position on that, at least at the time that we did our work, is that they knew that it was really complicated and they had revised their cost estimates, but they believed that they needed additional funding to do it.
Well, I'm not sure about that, but I want you to know that both Lloyd Doggett, who's a Democrat, by the way, and I agree that something needs to be done, and we've been working on this for, seems like, 8 years, and you guys haven't moved off dead center. Thank you, Mr. Chairman. Yield back.
Thank you. Just as a note, just the money saved from not paying felons, those who are dead, and those who are here undocumented would pay for the implementation of removal of those Social Security numbers. Mr. Blumenthal?
Thank you, Mr. Chairman. And I do appreciate what you and our ranking member have done in terms of moving forward with this and setting the stage for it. And I share both the sense of the urgency and the potential of doing something. You may have noticed occasionally we're cranky around here and we don't always see eye to eye. But what has been outlined today and what you're going to hear is an area, I think, of tremendous consensus. And beyond the consensus, I think there's a commitment and a passion to get something done. It doesn't make any difference about how you feel about the Affordable Care Act or global warming. These are uncontrovertible facts, and we're looking at 50, 60 billion, whatever the number is. Now, the individual areas in the vast payment scheme are maybe understandable, but the target number needs to be addressed aggressively. And you're going to hear from some of my colleagues. I'm not going to steer the thunder just because of the luck of the draw. A couple of my colleagues come after me, and I'll let them elaborate on their bills. But I am happy to have been a co-sponsor of the PRIME Act. I think my friend Mr. Roscom and a number of people have zeroed in. There's about 60 bipartisan co-sponsors with provisions that would probably welcome some refinement, but the essentials there are solid and need to be pursued. I've been working for several years with Mr. Gerlach on a universal access card. And I think, if anything, it started a little timid. It's been, you know, it has been very careful and calculated to try and move this forward. And I think he's going to weigh forth. And I couldn't agree more with Congressman Johnson about getting the flipping numbers off the Social Security card. We understand that it takes resources and takes time. And you've had a lot going on. But we're into a phase now of implementation of the Affordable Care Act, and you've had time. And I think that there is, this is something that is not rocket science. And I think people would be open to what needs to happen in terms of some modification of a budget going forward. But it's going, these things collectively are going to save far more than they're going to cost. And it speaks to the integrity of the system and the protection of the people that we represent. And Mr. Chairman, I would hope that we could continue with a little deeper dive on some of these proposals. I would hope that these would be at sort of a level, and I've talked with some of my colleagues about what would happen if we took some of, and we've had this conversation, we take some of the things that are second or third tier issues that don't have to, you know, stop the planet, the leadership doesn't much care in either party, to break some of this stuff loose, be with it on the floor. Maybe that would be a going away present. Mr. Roscom and I talked about this last week to members of Congress, that this would be kind of a wrap-up session that we would have on the Thursday or Friday when we leave, to have one of these specifics on the floor that could bring people together, that would make a difference, that would be a signal to the people out there who are cheating, and more important, to the people that we're representing. So I will get off my high horse. I won't go any further, because you need to hear from the people who are the principal authors and who have put huge amounts of work into it. But I would respectfully request, Mr. Chairman, that our witness friends could be able to give a little deeper analysis on each of these items that they're going to hear from, about how, about what we need to do that. And the last thing I would recommend is that we think about working with CBO on some scoring mechanisms, because things that actually save money, we ought to be able to apply present value accounting, particularly if we can hold agencies accountable for the savings. That this isn't a pipe dream, but this is something that is beyond theoretical, and that we have the hammer to go back and make sure that they deliver. Then maybe we can cut some slack in terms of CBO scoring. I appreciate your courtesy, Mr. Chairman. If there's something that my colleagues don't get to, I'll submit it to our witnesses in writing, but at this point, I'll yield back.
Thank you, Mr. Blumenauer. Two comments, if I may. One, this is a bipartisan concern. This is the first hearing of what we hope will be deeper dives, as you've laid out. And the goal is to begin moving legislation in these areas. Secondly, I agree with you completely on the scoring challenge. Often very good ideas that we know will work and have proven to save money elsewhere are not given the score we think they deserve. We are eager to work with you and CBO on those issues, so thank you. Mr. Roscom is recognized.
Thank you, Mr. Chairman, for your leadership in convening this hearing, and for Mr. Blumenauer and his thoughtful setting of this, the discussion. I think most Americans, when they hear these numbers, are actually scandalized by them. It's very difficult to absorb. We're in this very sort of clinical antiseptic setting, but this is a situation that's bad, it's been bad, and it's actually getting worse. This is not getting better. And these are the numbers, these are objective numbers. So CMS's own numbers in 2010 said that this number in terms of fraud and abuse and waste and so forth was $48 billion. A year later, it jumped up, according to GAO, to $64 billion. The latest estimate from the FBI is $75 billion plus and climbing. So, Doctor, with due respect, in my view, you don't get to use words like top priority, robust, and strongly positive. They should be out of your lexicon. This is a scandal. This is an embarrassment. And there's an irony in that Ms. Jarman, in her opening statement, makes an inquiry of this committee, would you please support our request for a budget and appropriation? And the irony is, you've got all the money already. So can you imagine the level of confidence that would be buoyant in our country if we were able to come together? And you've brought us together in ways that we've never been brought together before. As Mr. Blumenauer alluded, we can hardly agree what time it is between the two of our parties. We cannot agree on what day of the week it is. And yet we are nearly unanimously scandalized by just these big, big numbers. And so I just have I've got three inquiries of you, and I recognize you're the new person on the job. You've been there 2 months. So I'm measured by that, but so here's three legitimate issues that are upon us that have broken through. One is the Medi-Medi data sharing. This is this whole notion of Medicaid and Medicare being in communication. If there's fraud in one area, communicating that in another area. Right now, only 10 states are participating. In my view, that's ridiculous. What's your remedy to that?
Thank you. I think the Medi-Medi program is very important for our activities. It does, as you pointed out, allow us to exchange data with the states so that we can, again, find those providers and schemes that are crossing the line between Medicare and Medicaid and kind of committing schemes against us all. Expansion is an important element of that, and we have been working to expand the number of states that participate in Medi-Medi. This is, I would just point out, a voluntary program, and there are a number of other data exchange activities that the states are engaged in. We've heard consistently from them that while they would, in some cases, value participation, they have to weigh that against other priorities and data exchanges that they have. So we are very open to more expansion, have actually added more states since that figure of 10, and I could get you a more updated number.
So the next time we meet in a hearing setting so that you can claim those superlatives that I admonished you from using before, what's your plan in terms of the Medi-Medi goal? Let's say you're back in a hearing in 6 months. There's currently 10 states that are participating. What is reasonable for us to assume? Reasonable. I'm not asking pipe dreams. What is a reasonable number for you to coax, cajole, urge states to participate if only 20% of the nation is participating now?
I'm not sure that I could give you a specific number.
Sure you can.
That would, to kind of, for a follow-up hearing. I think what is important to note is that Medi-Medi is just one of the many activities that we perform with the states. We also collaborate with them in the Medicaid Integrity Institute, which is all about best practice and knowledge sharing. We work with them on specific cases that might fall out of the Medi-Medi context, but are active investigations either that we've initiated or that they have. So I'm not sure that participation alone in Medi-Medi is the best measure of how well we're
but it'd
collaborating
help.
with the
I mean,
states.
my home state of Illinois just paid out $12 million to people who were dead.
Yes, sir. I also am aware of that. I think I go back to the answer that I had about Medi-Medi. If you're asking specifically about Illinois, I could certainly look into what activities we have with them.
So here's my question. If only 10 states are participating, and we're losing $75 billion a year, according to the FBI, doesn't it follow that if we had every state participating, that this gets better? And don't you play a key role in whether every state participates or not? Am I over-characterizing this?
I think it's fair to say we too want more states to participate. I think.
What's your plan to have that happen? That's my question.
So we have lots of outreach activities with the states to let them know about the existence of the program, to indicate the sort of portion of the Medi budget that we are willing and able to handle versus what they would need to undertake. And we engage with states in numerous different venues in order to be able to do that. Again, I believe states are under a lot of pressure to also produce data for CMS, including the TMSIS program. So there will be exchange of data, and I'm not sure, again, that Medi is the singular kind of measure of that collaboration.
But you're not satisfied with 10 states, are you?
Oh, we always want more states to collaborate.
How many more? Next time we meet, how many more is a reasonable number?
Sir, I'm not sure I could give you a particular
Okay, let's
number.
switch gears. Provider legitimacy. This notion of a provider being illegitimate, losing a license, being a hustler, and so forth, being thrown out of a system, and yet that doesn't sync up with other systems. There was a Publica piece not long ago. I'm sure you're familiar with it. Could you speak to that?
Sure, and I think that's a great example of data exchange outside of the Medi program. So, for example, as a result of the ACA, Medicaid programs are now required to share their termination data with CMS, and we are then able to take relevant action in Medicare if that provider is indeed enrolled in Medicare, as well as take reciprocal action in other state Medicaid programs. I think there are very good examples. We've had compliance in sharing that kind of data increase dramatically since the beginning of the program. We get a lot more information from the states in terminations that they're able to perform. Now, I would point out, licensure decisions are very different from enrollment in Medicare or Medicaid. Those are conducted by non-CMS affiliated bodies. Those are state licensure boards. They operate very independently of us. We certainly can take an action if a license is revoked, but we, as such, have no more authority in that process than anybody outside the licensure board.
Okay, we'd love to help you. I yield back.
Thank you.
Thank you. Mr. Kynes recognized.
Thank you, Mr. Chairman. I commend you for holding this important hearing, and it is one that really should be nonpartisan, and hopefully we'll have an opportunity to work in a bipartisan way. You're never going to find any member of Congress defending fraud, waste, and abuse, whether it's Medicare or any other federal program, but I think we need to approach this in the proper context. It's not just Medicare fraud that we're talking about here. We're talking about system-wide health care fraud, and Medicare is a subset of that. I would assume that if we're detecting fraudulent practices, fraudulent billing in Medicare, it's much larger than that. It involves private payers and those involved in the healthcare system. Is that right, Dr. Agrawal?
Yes, I think that's a very important point. Part of the reason for the creation of the Healthcare Fraud Prevention Partnership is this very notion that fraud crosses the public-private divide, and the fact that private payers have joined the partnership really does indicate that they face these challenges too.
And that the private partnership program right now, how successful do you think that has been working, the collaboration with the private sector and the private payers, and what more do you think could be added to it in order to enhance its success?
Thank you. I appreciate the question. The collaboration has been extensive. For example, in next week, a number of private payers are going to be coming to the command center at CPI as part of partnership activities. We have over 30 partners at this point between private payers, national healthcare agencies, law enforcement bodies. We've conducted numerous data exchanges within the confines of the partnership, specific data exchanges, not just qualitative data around best practices, though we have done that as well. And each of us has then used that data, each participant has used that data to go and take action wherever appropriate in our own systems, and CMS has been able to do that. So I think the partnership has really continued to mature.
Yeah, you know, Mr. Roscom did point out some startling numbers as far as trend lines from 48 billion to 75 billion or so, but I also sense there's a little bit of the dial being moved in the right direction as well. I mean, because of the existing tools now in the Affordable Care Act and some pre-existing authorities, we've got the heat strike force that's been out there. I think since passage of ACA, over 20 billion has been recouped or recaptured of Medicare fraud. 1,400 individuals have been charged up, and criminal charges are pending against. So there are some instances that we can point to showing some progress is made, but obviously there's no reason for a victory lap or satisfaction from any of us here. My question for you, Doctor, coming from the profession yourself, we just had a huge CMS physician reimbursement data dump recently. Where do you think this is going to lead as far as looking at overutilization practices and possible fraudulent detection?
Thank you. I think that data release was a very important element of the administration's overall approach to transparency in healthcare data. Since then, we've heard from a lot of external stakeholders about their use of the data, how they would like to leverage it. I think that kind of innovation, among stakeholders is very important. It also fits into an overall kind of set of programs that we have at the Center for Program Integrity. Another example that we're implementing now is the Sunshine Act. That will allow more transparency into the financial interactions between industry and physicians. I think all of these programs are designed to give beneficiaries and other stakeholders a view into data. And one group that we've heard from pretty extensively is the physician community, especially, for example, in emergency medicine, where physicians have written back to CMS saying, thank you, this is data I did not have before. And it would help, it would facilitate their own practice.
I think to be fair to them, that was only a small piece of the information out there. What's lacking in that is quality measurements, protocols of care, things of that nature, and what the overall success rate and how doctors are practicing medicine. But finally, let me ask with the remaining time, with you, Doctor, and I'd also like to hear Ms. Jarman and Ms. King's opinion, but we're trying to move the system, the payment system, away from fee-for-service and volume-based to outcome and value-based. And obviously, we're seeing a lot of effort in bundled payments as well. What are the implications of that new payment model when it comes to the detection of fraud and how successful? Because obviously under the fee-for-service model, there are a lot of reporting, a lot of steps that people are being reimbursed for. Is this going to make it easier or harder for us to detect fraud, moving to a more bundled form of payment system or a value-based system ultimately?
Yeah, thank you for that question as well. I think the movement, obviously, towards value is extremely important. It's a central tenet of the ACA. And that movement is important for healthcare overall. I think while I'll sort of leave the specifics of new payment models to the experts at CMS who handle the new payment models, what I would just want to clarify is that none of the payment models that are new and innovative preclude us from performing the activities that we already have in place for fee-for-service. We are still able to conduct the medical review that we conduct. We can still open up investigations and take appropriate actions, whether a provider is participating in just traditional fee-for-service or one of the newer models. So we still have and continue to have the same level of oversight and have the same level of authority. So I think as the new systems mature, certainly it will be an opportunity for all of us to learn more, but the oversight and the controls are still very much there.
Okay, thank you.
Thank you,
Mr.
Doctor.
Chairman.
Dr. Price?
Thank you, Mr. Chairman. I want to thank the panelists as well. Having practiced medicine for over 20 years before I got here, I think, as I mentioned, often we lose sight of the patients in all of this. We all want to save money. None of us want to have fraud exist out there, pay for folks that are scamming the system. But sometimes that money that's taken is taken from folks who are actually trying to provide care and potentially destroying the quality of health care for seniors. And so it's important that we have a feedback mechanism to be able to tell whether or not we're actually doing the right thing. Ms. King, there was a GAO report that was released earlier this month on the competitive bidding program for durable medical equipment, DME, including home oxygen supply and the like. And these are services that affect real lives, make it whether or not individuals can actually live a comfortable life or whether or not they live at all. And again, we all want to hold contractors accountable. The OIG found, we're into round two, nearly 2 years into round two, the OIG found that there were problems and concerns that they had with round one, and yet we went ahead, y'all went ahead, CMS went ahead with round two. GAO said that was a good idea. Recently, your report said that there was decreased utilization of durable medical equipment, there was decrease in suppliers, and no adverse effect to the beneficiaries. So if you read the top line of that, and you jump up and down, you say, hallelujah, that's a wonderful thing. Are you aware of any of the concerns that have been voiced about this by the COPD, the Chronic Obstructive Pulmonary Disease Foundation?
Not specifically the COPD Foundation, but we've done a considerable amount of work on the implementation of competitive bidding for DME.
Did you interview them for your report?
I don't know, but I can get back to you on that.
How did you decide who you interviewed for your report?
we laid out the methodology in our report, and we have a very transparent methodology, and we contacted a number of people in the industry and met with them several times, but I don't recall whether they included the COPD folks.
I don't think you did. I would encourage you to talk to them. They disagree strenuously with the conclusions that you've made and the recommendations that you provided. Did you use data that you had, or did you use CMS data in your evaluation?
We got claims data from them and did our own analysis.
Claims data.
Yes, we did. And
No clinical data.
no, they had clinical data, and they set up areas.
No, they have claims data. They have claims data, right?
Yeah, and
that's what we're looking at. Looking at claims data. We're looking at money, which is wise. We need to do that, but oftentimes we don't look at patients. Did you ask, or did you find out, or did your data tell you whether or not a patient that fell off wasn't utilizing the service anymore, whether they needed the service anymore? Could you tell that?
CMS did their own beneficiary satisfaction work, and we evaluated that. And in their work, they did not find significant access problems, and we
That wasn't what I asked. I asked, did you find it? Did you ask whether or not patients fall off? Do they go to self-pay? They pay for the service themselves, or do have they been transferred to a nursing home? Is there any way to know whether they've been transferred to a nursing home in the data that you used?
not that I'm aware of.
That's correct. These are chronic diseases. These are chronic diseases. And CMS says it only tracks data for 120 days. If you don't have a current claim within 120 days, they don't care. You could have gotten the pennies together in your sofa and paid for the oxygen to keep you alive, or you could pull it out of your pocket, or you could go to a nursing home, and CMS doesn't know. So I would suggest that we've got a long way to go toward getting the right data when you're talking about quality. When the federal government's defining quality, then anybody that doesn't do what the federal government wants to do is fraudulent. I would suggest that's not the right place to define quality. Let me just touch on, I've got a few more seconds here. Ms. Jarman, you mentioned about the in-office ancillary self-referral increased utilization. You are aware that there are studies and individuals, studies that have been done that demonstrate that that's not the case, that there's no increase in utilization with the use of in-office ancillaries. You're aware of that?
No, I was not aware of that.
All right. Well, we will get that for you, and we'll be happy to see the change in the next report. Ms. Jarman, there are, talking about the number of counties that have the kind of high incidence of home health outliers, 3,143 counties in the country, 25 counties have the highest incidence. Wouldn't we do a whole lot better job if we just concentrate on those 25 counties?
When we're doing our work, we do try to focus on the areas where there is higher risk. So we do try to focus on those areas in our analysis.
The work wouldn't demonstrate that, though, because we continue to have that same statistic year after year after year. So I'd encourage you to focus where the real problems are. Thank you, Mr. Chairman.
Thank you, Mr. Pascrell.
Thank you, Mr. Chairman. I'm encouraged that we can get some bipartisan support. One area that has been of particular interest to me is the hip and knee replacements. I first became involved in this issue in 2007 when 5 of the nation's biggest makers of artificial hips and knees agreed to pay $311 million in penalties to settle federal accusations that they used so-called consulting agreements, better known as bribes, and other tactics to get surgeons to use their products, regardless of the effectiveness of the product. So this may be the cost of doing business, but it's serious, because in the next 10 years, we're going to spend $65 billion on knee and hip replacements. Medicare and Medicaid will pick up most of the cost. So if we're not concerned in this particular issue and avoiding the debacle that happened just 10 years ago, what are we? Strong action was needed to be taken. And instead of anyone going to jail, no one went to jail. 5 companies got deferred prosecution agreements where they simply paid a fine and agreed to be monitored by private firms. That's not the subject of what I'm going to get into today, but let me tell you, your hair would stand up. Go back and read those cases. I introduced two bills then that I believe get at the root of the issues here. First is the Accountability and Deferred Prosecution Agreements Act, which will require the Department of Justice to establish guidelines for the use of deferred prosecution agreements. I plan to introduce this bill later this week. And second, the National Knee and Hip Replacement Registry Act, which would establish a registry to help identify failing implants and to identify best. We're talking about senior citizens that got shafted over and over again, had to be researched because of what we did not do. Make no mistake, problems with faulty joint implants are no means behind us. Just last year, one of the largest medical device companies agreed to pay $2.5 billion to settle lawsuits filed by thousands of patients who had to undergo, we're talking mostly seniors. That's what we're talking about. And in the next 10 years, again, we're going to spend $65 billion. By the way, do you agree that we should have a registry in this country so we know who's stealing from other people?
Well, sir, on the hip and knee registry, I think we'd be open to reviewing the proposal and offering you any guidance that would be helpful. I do think that we are aligned in certain other ways already. I alluded earlier to the Physician Payment Sunshine Act. We will be able to see through that program, as just one example, financial interactions between medical device companies and physicians. And I think that will be a level of data transparency.
Do you believe, doctor, that collecting patient data in a registry on knee and hip replacements could help us to identify ineffective knee and hip devices so that we can cut down on unnecessary surgery? Do you agree with that or you don't agree with it? It's a pretty simple question.
I think that we're happy to review any proposal that comes from this committee and help you in the evolution of that proposal.
Well, it would seem to me, if you know the history, and I was trying to give it to you in capsule form, unfortunately, back in 2007, much of it occurred before 2007. And you folks have not, even though you just came on the job, you folks have not done anything about this, encouraging anything. This is a major part of your budget. This is a major part of the fraud. It would seem to me that we should be interested in these kinds of things. Correct?
Yes, sir, I think we are interested. As I have alluded to a couple of times now, I think the Sunshine Act will get at this issue as well.
Mr. Chairman, I think that when we speak of trying to make the system better, and when we speak about trying to save money, because there is tremendous amount of fraud, and many people who committed the fraud never went to jail. Okay? Talk about our system of justice, about when you have a buck in your pocket, you stay out of jail. When you don't have a buck, you're sure the hell will go to jail. And one way is to stop this, is to look at this registry, which I'm talking about here, so that one hand knows what the other is doing. And I think it would reduce health care costs, period. Not only in this area, but in other areas, and I yield back and I thank you.
No, thank you, Mr. Pasquale. Mr. Smith.
Thank you, Mr. Chairman, and thank you to our witnesses here today for sharing your insight. It's a tough job out there that I think you're trying to do, and it's frustrating from our standpoint. I get especially frustrated when I hear from providers wanting to do the right thing, and yet it is so cumbersome, it is so complex, that even doing the right thing has become so difficult. And I'm afraid that that's just getting worse. And we know that Medicare is on an unsustainable path, at least that's my opinion, and we need to make some changes. We did hear about the embarrassing situations of improper payments, Ms. Jarman, and how, I mean, any of you, how do these improper payments happen? What can you tell us is being done to fix this? Dr. Agarwal?
Sure. One thing I would just want to clarify is certainly the improper payment rate is a huge focus for the agency, and we are focused on reducing the improper payment rate. I just want to differentiate that rate from a measure of fraud. The improper payment rate is not a true measure of fraud. It is really more a measure of perhaps waste and abuse. A lot of the major drivers of the improper payment rate are insufficient documentation, which is often caused by providers sometimes not understanding regulatory requirements. But if we got the documentation that was required, chances are those claims would have been just fine.
So services for a dead person, how does that happen?
Yeah, so there are, we
Would
utilize...
that be fraud or would that be improper payment?
It could be either. I think obviously, establishing fraud depends on establishing intent, and that really is a law enforcement determination. What we do is we look at drivers of improper payment and try to go after the biggest drivers. With respect to dead beneficiaries or dead providers in specific, we work very closely with the Social Security Administration to get information on their death master file and to be able to link that information to our own data so that we can stop claims from being paid for those beneficiaries or to those providers.
So would you say that current measures are sufficient? More measures are needed? Lack of enforcement? How would you sum up what the current situation is or needs to be?
Well, I think if you were to look at the improper payment overall, certainly, there is more that we can do, and we are working on various initiatives to decrease the improper payment rate. Again, because documentation issues drive a huge portion of that rate, we are working with providers to educate them on real documentation requirements. Some of the other things that drive the rate are medically necessary services, but being provided in the wrong place. So again, that does come down to education and working with providers.
In the wrong place. Could you elaborate?
Sure. So there might be a service like a stress test, for example, that's provided in an inpatient setting that could be provided in an office or outpatient setting. That inpatient claim would actually could potentially lead to an improper payment, depending on how it was documented and all that. But nobody's contending necessarily that the service should not have been provided. It should just have been provided in a more medically reasonable location. So a lot of that, again, does come down to working with providers. I take your point very seriously about provider burden and agree as a physician myself that we should do whatever we can to lower burden as feasible while still meeting our obligations to protect trust fund dollars and educating providers as best we can on the front end so mistakes are not made.
Well, I would also add, as I have in previous hearings, in working on healthcare issues, especially in rural America, there are arbitrary regulations that I think might be intended for greater efficiencies, and yet the result is the exact opposite. And I'm afraid patients actually suffer as a result of the federal bureaucracy and supposedly in the name of striving for efficiency, but services are worse. I think it's arbitrary, and I would hope that we could have your cooperation as we do move forward on trying to find some efficiencies there. We know that hardworking taxpayers need protection, so to speak, and that we have, I think, many options ahead of us. Hopefully we will pursue that will have the federal government step back instead of step forward and into the lives of so many patients, because I think it's counterproductive. Thank you. I yield back.
Thank you. Mr. Gerlach?
Thank you, Mr. Chairman. Thank you all for coming and testifying today. The amount of fraud and abuse in the program is staggering. We all know that. And I relate it back to just where I'm from, Pennsylvania. The Commonwealth of Pennsylvania's state budget is about $32 billion a year. So really what we're talking about here is fraud and abuse in one program of the federal government that is double the size of the Commonwealth of Pennsylvania's budget each year. That's staggering. And I'm really concerned that in the years that I've been on this committee and we've had these kinds of hearings, very little progress has been made to deal with it from the witness side of things, where the same questions have been asked by Mr. Johnson year after year after year, why there's still Social Security numbers on these cards, still don't have a solid answer as to what you're doing about it. And frankly, not to take it personally, you ought to be embarrassed. You ought to be embarrassed for the agency you work for and for the American people. Now, that doesn't mean you're personally responsible for that, so please don't take that as a personal slight to any of you. But it ought to just remind you, as you sit here today, how important these issues are and how important it is to make progress on these issues. And I hope a year from now, you're not back testifying and you're giving the same answers to the same questions and no progress has been made. A number of us on this committee, my lead co-sponsor, Mr. Blumenauer, and other members of this subcommittee have co-sponsored H.R. 3024, which will create a smart card program within the Medicare program to deal with this issue. Having both the provider and the beneficiary have a card without a Social Security number on it that would be swiped at the time of the medical transaction to try to reduce fraud and abuse, and in particularly deal with fraudulent billing, phantom billing, duplicate billing, dealing with unlawfully present beneficiaries, dealing with deceased beneficiaries, dealing with identity theft. We think this kind of technology, which already is being used in the Department of Defense to prevent people from getting access to certain buildings of the department or into computer systems, being used perhaps by yourselves. I understand all federal employees have a Homeland Security technology card that they use. Other healthcare delivery systems around the world are using smart card technology to deal with waste, fraud, and abuse. Yet here in the United States, we don't have that as part of our program, and we also include the Social Security numbers on our cards. So a number of us, not only here in the House, but also on a bipartisan, bicameral basis, have sponsored this kind of legislation to bring smart card technology into the program. And we've asked GAO, Ms. King, I know you're well aware, we've asked GAO to do some preliminary background evaluation of the idea. Ms. King, can you give us an update as to what the work you're doing in GAO with this particular idea, where you might be in that process, and when do you think there would be a completion to that so that we can move forward with evaluating that information from you and then move forward legislatively?
Yes, thank you for that question. At your request and the request of several other members of Congress, we are looking at the use of electronic cards in Medicare, and we're looking at several aspects of that. We want to try and find out what the potential benefits and any limitations, if there are any, with the use of them, what issues might be involved in the implementation of smart cards, and we also want to evaluate where they're in use in other settings. And we hope to finish up that work about the end of the year.
Okay. And then will you come back to us with a report and recommendations relative to the idea?
We will.
Okay. Doctor, on that same idea, are you currently out of your shop looking at the use of digital technology solutions to more accurately authenticate providers and beneficiaries at the time of the medical transaction rather than continuing this pay and chase process we have today? Having more front-end verification methods in place could include smart card technology, could include other types of technology to again address this issue?
Yes. Well, obviously, we do look forward to seeing GAO's findings. That will certainly help the agency as well. We did conduct a little while ago a swipe card pilot with DME ordering that basically required or allowed providers to swipe an electronic card at the time of the order being placed in the office, and then a beneficiary taking that card essentially to a DME supplier to be able to connect the order in the office to the supply that was actually given. And I think the outcomes of that program have highlighted, some of the challenges that might emerge in this report as well. Number one, there are obviously some operational constraints that we should be aware of on the part of the provider. I think we have to be very careful in instituting any kind of alternative technology approach that we not place too much of a burden on providers, that we not, whether it's a resource burden or other kind of technology acquisition burden. Secondly, I would just highlight or emphasize that in any new technology implementation, we not get in the way of the physician-patient relationship. This was actually some specific feedback that we got to our pilot that certain physicians saw that as an intrusion, having to swipe a card when they were seeing a patient. Obviously, beyond that, there are other operational constraints of implementation, but I would just ask the committee to keep these things in mind.
We'll look forward to your information. Thank you.
Mr. Chairman, just a point of personal privilege. Just, I would note that this particular project of Mr. Gerlach, he has unfortunately decided that he's not going to be with us next year. And I'm pained with the notion that we're not going to get a report for 6 months. Is it possible to get some sort of interim report in the next few months that could feed back into the work we're doing here, and that we might be able to wrap this up? He's invested years in this, very positive idea. Is there some way that we could get a little something sooner?
We're not at the point right now of being able to tell you what our preliminary findings are, but I think we will be before the end of the year.
Yes, and I'm just saying respectfully, because we have a different timetable here. If there's some way, even not a final preliminary, but something that would give guidance sooner, late in the summer or early in the fall, it would make a big
And
difference.
Ms. King, I'd imagine every one of us would add our support for that request as well. Right, thank you. Thank you, Mr. Gurley. Ms. Black?
Thank you, Mr. Chairman, and I do sincerely appreciate the opportunity to participate in this hearing. And I thank you for your leadership on this issue. This is a very important issue in understanding the fraud, waste, and abuse in the Medicare program. I, as many of myself and all the colleagues that have spoken here, do have serious concerns about the future of Medicare, the program, and appreciate viewing some of the recommendations that have been made by the GAO that has been published in order for CMS to address some of these fundamental structural changes that are facing our growing system. I think it was my colleague, Mr. Roscom, that made mention $75 billion when I think about billions of dollars that potentially cannot be accounted for. It's a tremendous, tremendous amount of money. I certainly appreciate the good work that is done by both the GAO and the Inspector General as well. Just recently, I sent a letter to Ms. Tavender on this very topic to understand why CMS has not adopted 2 recommendations made by GAO to reduce improper payments issued by CMS. One of them goes back pretty far, and we still don't see that there's been a resolution on this. It goes back to a 2007 GAO recommendation that was a requirement for contractors to develop thresholds for unexplained increases in billing in order to implement the controls under an automated payment system. And prior to issuing these payments under a fee-for-service, thresholds have not been developed to explain unexpected increases in billing. And that seems to me to be one that just ought to jump out and ought to be one that takes priority to say, why is that happening? And let's put thresholds there so we can at least catch that, as has already been said by the previous questioner. Dr. Agarwal, would you be able to help me understand why this still has not been put into place?
Sure. We do have models. So we have the fraud prevention system, which is a predictive analytics system that allows us to look at claims in real time. One of the models in that system does look at the type of spike billing that you are talking about, essentially significant changes in billing behavior in a relatively brief period of time. We also have other models that look at just the absolute dollars that are going out. So, some that look at the change and others that just look at high dollar amounts. We could perhaps work with the GAO to close that recommendation, but I do believe we have addressed it.
Well, if you have, I think it would be a great idea to work with GAO because it continues to show up in the recommendations. And if we go all the way back to 2007, we see this continue to be a recommendation that hasn't been closed. Then there is a question about why is that? A lot of money is spent with the GAO in trying to get these recommendations to you all, because understanding that you're very busy on administering the program. But I think when they are given, they need to be taken seriously, and we don't need to see them being open year after year. I want to go to just one other one, and I'm interested in the recommendation that was made by GAO regarding the home health agencies with known high rates of improper billing. The GAO recommended that the CMS conduct post-payment reviews, and that also seems to have not been done yet. Can you speak to that?
Yes, ma'am. So we receive regular reports from our zone program integrity contractors that conduct investigations against various providers that have, risen in priority. Each one of our zone program integrity contractors does conduct post-pay reviews of home health agencies in their zones. Again, this perhaps may be a recommendation that we could close. In specific, the committee is aware of the moratorium that we have implemented in home health services in a number of different geographies. As a result of those activities and other activities, as just one example, we have revoked over 100 home health agencies in just Miami alone in the last year, half of them after the moratorium was put in place. So home health care is something that we are closely looking at. We, in fact, do conduct post-pay audits and payment suspensions and prepay reviews just in alignment with our other authorities. So I'd be happy to work with them to perhaps close that recommendation.
Just an observation that you did talk about several of these recommendations that you all are trying to address. I think that since you're fairly new with the organization, the agency, that it might be a good change in culture to go back and look at these and be able to report back to this committee in particular, but to Congress in general, to let them know that you are taking these recommendations seriously. Because, as I say, there is a lot of money that goes into researching these recommendations and giving them to CMS. And I would hope that we would have you close those out. If you're really doing these, let us know. And let us know also how much has been saved. If you can help us to know that, that's very helpful. Thank you, Mr. Chairman.
Thank you, Ms. Black. To the witnesses, thank you for being here. The frustration you hear bipartisanly expressed is not because fraud in Medicare is new. It's not. It is growing as the program is growing. It at times seems superhuman and immortal, and it's not. Much of the fraud and abuse we've seen is preventable. And so, one, this won't be the last time you're before the subcommittee. We are dead serious about both aggressive oversight to ensure that the recommendations by the Inspector General and GAO are implemented in a timely way by the agency. Appreciate your support and commitment to work with us to do that. Secondly, the subcommittee hopes to develop in advance a package of legislative bills related to fraud. So if you have views on the legislation that you heard from the members today, I would encourage you to get with them immediately, because we intend to move on the area of fraud. With that, I'd like to thank all of our witnesses for their testimony today. Appreciate their continued assistance getting answers to the questions that were asked by our committee and members. As a reminder, any member wishing to submit a question for the record will have 14 days to do so. Any questions are submitted, I ask the witnesses respond in a timely manner. With that, subcommittee is adjourned.